Hello friends, today we are going to discuss about the organophosphorus poisoning. Organophosphorus compounds are the chemical agent in widespread use throughout the world, mainly in agriculture field. They are also used as nerve agent in the chemical warfare, as therapeutic agents such as ecothiopate used in treatment of the glaucoma. They comprise the ester, amide, and thiol derivative of the phosphoric acid, and they are commonly used as pesticide in commercial agriculture fields, spray, and household chemical. So organophosphates, they are of significant importance due to their practical usefulness and chemical instability. So regarding classification, the classification of the organophosphate compound is according to their toxicity. It is classified as highly toxic, intermediate toxic, and low toxic. So highly toxic is tetraethyl pyrophosphates and parathion. They are mainly used in the agriculture insecticide. And intermediate toxics are comafos, chlorpyrifos, and then trichlorophone. They are used as the animal insecticide. And the low toxic compounds include diazinon, malathion, and dichlorose. They are used for household application and the field spray. Now, regarding the mechanism of action of organophosphorus compound, acetylcholine is the neurotransmitter released at postganglionic parasympathetic nerve ending and at the synapses of sympathetic and parasympathetic ganglia. It is also released into the skeletal muscle myoneural junction, and it is served as neurotransmitter into the central nervous system. So this acetylcholine is normally hydrolyzed by acetylcholine esterase into two fragments, like acetic acid and the choline. And this acetylcholine esterase is present into the two form, that is true acetylcholine esterase, which found primarily in the tissue, erythrocyte, and pseudocholine esterase, which found in the serum and the liver. So organophosphorus compounds are the acid-forming inhibitors of acetylcholine esterase. So they cause acetylcholine esterase to become firmly phosphorylate. This means that action of the cholinesterase will be inhibited. And the cleavage of carbon enzyme bond of acetylcholine is complete in few microseconds. However, the breaking of phosphorus enzyme bond requires the period varying from the 60 minutes to several weeks, depending upon the organophosphorus compound involved. So the reactivation of the inhibited enzyme may occur spontaneously, and the reactivation will depend upon the species, tissues, and the chemical group attached to the enzyme. This reactivation is enhanced by the hydrolysis of acid radical enzyme through the use of oxen. And response to the reactivating agent decline with the time, this process being caused by aging of inhibited enzyme. Aging is probably the result of loss of one alkyl or alkoxy group, leaving a much more stable acetylcholine esters. So the aged phosphorylate enzyme cannot be reactivated by oxides. Now, the accumulation of the acetylcholine causes the overstimulation of both muscarinic as well as nicotinic receptor and subsequently disrupt the transmission of the nerve impulse in both peripheral and central nervous system. So, this is the schematic representation of this organophosphorus compound, toxicity of the organophosphorus compound. This organophosphorus compound is bind into the cholinesterase enzyme, which resulted into the formation of phosphorylated cholinesterase enzyme. So the normal function of cholinesterase, which is the degradation of the acetylcholine, is not performed, and there will be the accumulation of the acetylcholine into the nerve terminus, which results into the muscarinic as well as nicotinic effect. So most organophosphates are highly lipid soluble compounds, and they are easily absorbed from the intact skin, oral mucosal membrane, conjunctiva, gastrointestinal, and the respiratory tract. And they are redistributed to all body tissues. The highest concentrations are found into the liver and the kidney. This high lipid solubility means that they easily cross the blood-brain barrier and therefore potent effect, and they produces the potent effect of the CNS. Now, the metabolism occur principally by the oxidation in the liver with conjugation and esterase hydrolysis, producing half-life of the minutes to hours. Oxidative metabolites of the malathion and parathion, these are the active form, and they are subsequently inactive hydrolyzed into inactive metabolites. Elimination of organophosphorus compound and its metabolites occur mainly via urine, bile, and the feces. The clinical feature of the organophosphorus poison. Following exposure to the organophosphorus compound, the toxic features are usually obvious within 30 minutes to 3 hours. This may be delayed in some cases depending on the rate and the amount of systemic absorption. The majority of the patient give the history of intentional or accidental ingestion of organophosphorus compound, and the toxicity is produced by the rapid absorption of the compound through the gastrointestinal, respiratory tract, and skin. Clinical symptoms and signs are non-specific and will depend upon the specific agent, quantity, and the route of entry. Some patients present with the vomiting, diarrhea, abdominal pain, while others may be unconscious on arrival at the hospital. A high index of suspicion is therefore needed to make an early diagnosis. So the clinical features of organophosphorus poisoning is classically divided into muscarinic is there due to muscarinic effect, nicotinic effect, and central receptor stimulation. So early cases will be predominantly with the parasympathetic overactivity and characteristic garlic smell. The end result may be multisystem manifestation involving gastrointestinal, respiratory, cardiovascular, and nervous system, as well as involvement of skeletal muscle, other organ, and metabolic effects such as hypo and hyperglycemia. Most fatalities occur within 24 hours, and those who recover usually do so within 10 days. So, cardiac manifestations are the commonest cardiac manifestation following poison are hypotension and bradycardia. Patients seldom present with the tachycardia and hypertension due to predominant nicotinic receptor blockage. Cardiac manifestations are often cause of serious complications and the fatality. So ECG manifestation include prolonged QTC interval, elevation of ST segment, inverted T waves, and the prolonged PR. There may be rhythm abnormalities such as sinus bradycardia, ventricular extrasystole, ventricular tachycardia, and fibrillation. There are three phases of cardiac toxicity following organophosphate poison. Phase 1 is the brief period of increased sympathetic tone. Phase 2 is the prolonged period of parasympathetic activity, including EV node blockage. Phase 3 is the QT prolongation followed by torsitis deep pointers, ventricular tachycardia, and ventricular fibrillation. The mechanism of cardiac toxicity is unclear and following have been postulated. The direct toxic effect on the cardiac on myocardium, overactivity of cholinergic and nicotinic receptor causing hemodynamic alteration, then hypoxia, acidosis, electrolyte abnormalities, and high dose of atropine, which we are using for the treatment of organophosphate poison. Now, let's talk about respiratory manifestation. Respiratory manifestation of acute organophosphorus poisoning is including bronchoria, rhinorrhea, bronchospasm, and the laryngeal spasm. This is due to action of organophosphate on the muscarinic receptor. The integrity of the airway may be compromised by excessive secretion. And the nicotinic effect is leading into the weakness and subsequent paralysis of respiratory and oropharyngeal muscles. This increases the likelihood of both airway obstruction and aspiration of gastric content. Finally, the central neurological depression may lead to respiratory arrest. Now, gastrointestinal manifestation. Symptoms resembling the gastroenteritis, such as vomiting, diarrhea, and abdominal cramps, are the first to occur after oral ingestion of organophosphorus compound. Then, regarding neurological manifestation, a large number of patients following acute exposure to organophosphorus compound will require prolonged ventilatory support in intensive care unit due to neuromuscular weakness. The neurologic manifestations have therefore been a primary focus of interest. There have been emphasis on the reducing the incidence of neuromuscular respiratory failure. Three different types of paralysis are recognized based largely on the time of occurrence and their differing pathology. Type 1 paralysis is acute paralysis. Type 2 paralysis or intermediate syndrome. Type 3 paralysis or organophosphate induced delayed polyneuropathy. So acute paralysis is seen in the initial cholinergic phase. This is when large number of both muscarinic and nicotinic receptors are occupied by acetylcholine, leading to the persistent depolarization at neuromuscular junction. Clinical features include muscle fasciculation, cramps, twitching, and weakness. At this stage, the patient may require ventilatory support due to weakness of respiratory muscle, leading into respiratory depression and arrest. Type 2 or intermediate syndrome. This was first described in 1974 by Vadia et al. As type 2 paralysis and subsequently termed as intermediate syndrome. This syndrome develops 24 to 96 hours after the poisoning. Following recovery from the acute cholinergic crisis and before the expected onset of delayed neuropathy, some patients develop a state of muscle paralysis. The cardinal features of the syndrome is muscular weakness affecting the proximal limb muscles and neck flexor, which relatively spares distal muscle growth. One of the earliest manifestation in this patient is the inability to lift the head from the pillow. This is useful test to establish whether or not the patient is likely to develop respiratory muscle weakness. Of the cranial nerve, those supplying extraocular muscles are mostly involved, with lesser effect on the cranial nerve 7 and 10. This syndrome is persist for 4 to 18 days, and most patients will survive unless infection and cardiac arrhythmia complicate the course. Then type 3 paralysis is the organophosphate-induced delayed polyneuropathy. It is the sensory motor distal axonal neuropathy that usually occurs after ingestion of large doses of organophosphorus compound. The neuropathy presents as weakness and ataxia following latent period of 2 to 4 weeks. Initial stimulation causes the excitatory fasciculation, which then progresses into the inhibitory paralysis. The cardinal symptoms are distal weakness of hands and feet. This is often preceded by calf pain and in some cases paresthesia of distal part of the limb. Delayed CNS signs include tremor, anxiety, and coma. Now regarding diagnosis, because as there is no clinical feature which are specific to organophosphorus compound, the diagnosis requires high index of suspicion. The combination of history of exposure and typical clinical feature make the diagnosis of organophosphorus poisoning relatively easy. The history of exposure may be denied by patients who have attempted suicide or unavailable in the unconscious patients. So helpful sign of poisoning include pungent garlic-like odor of organophosphorus in breath and vomiters. Then other signs are meiosis, bradycardia, and muscle fasciculation. Excessive salivation, excessive respiratory tract secretion, and lacrimation are the other helpful signs. It should be remembered that some patient may represent with nicotinic effects of tachycardia, hypertension, and mydriasis. So, diagnosis of organophosphorus poisoning should ideally be confirmed with assay to measure butyrylcholinesterase activity in the plasma or acetylcholinesterase in the whole blood. Unfortunately, much confusion exists about the use and the interpretation of the assay. So, some pesticide inhibits the butyrylcholinesterase more effectively than they inhibit acetylcholinesterase. Butyrylcholinesterase activity does not relate to the severity of poisoning. It can be used as sensitive marker of exposure to the most organophosphorus compound, other cholinesterase inhibiting compound, and for measuring organophosphorus elimination from the body. Red cell acetylcholinesterase is the good marker of synaptic function and atropine needs in patient poisoned with organophosphorus and is therefore probably the good marker of severity. So patient with red cell acetylcholinesterase activity of at least 30% had normal muscle function and no need of atrophy. By contrast, patients with less than 10% of normal red cell acetylcholinesterase activity had grossly deranged muscle function and need high doses of atropine. So, acetylcholinesterase activity between these two values are associated with moderate impairment of muscle function and need for atropine. Now, regarding management, so first is skin decontamination. This is important step because, as I have already mentioned, the absorption of the organophosphorus compound will occur via the skin. So, it's very important to decontaminate the skin of the patient. Then airway protection is indicated, gastric lavage, activated charcoal 0.5 to 1 gram per kg every 4 hourly. Then anticholinesterase activity, anticholinesterase activity which is induced by atropine. Cholinesterase reactivator is the pyridoxine, ventilator support, inotropic support, and feeding is enteral or parenteral. So first is skin decontamination. It is very important step that should not be neglected or the hurry. So patients should be removed from the site of exposure and their clothes should be removed. Patient's body should then thoroughly wash with the soap and the water to prevent further absorption from the skin. Prior to treating the patient, staff should be protected from organophosphate by wearing gloves, gown, and the eye protectors. Gastric emptying should then be considered if the patient present within the 1 hour of the ingestion. Gastric lavage is the only means of emptying stomach in unconscious patient in which airway needs to be protected. The patient should receive the activated charcoal 0.5 to 1 gram per kg every 4 hours to promote the absorption into gastrointestinal tract. Lavage is preferred to enforce MSS as this may precipitate seizure. Then airway and respiration. Airway should be secured and adequate oxygenation should be ensured. This is important as atropine can precipitate ventricular fibrillation in hypoxic patients. Paradoxically, the early use of adequate atropine will dry respiratory secretion, improve muscular weakness, and thereby improve oxygenation. So, careful observation of respiratory status is required as these patients are prone to develop respiratory failure during both acute phase and intermediate symptoms. The following should be monitored on regular basis to assess the patient's respiratory status, like respiratory rate, tidal volume, vital capacity, neck muscle weakness, ocular muscle involvement that is diplopia, and ABG. Now, regarding cardiac monitoring, as mentioned earlier, a wide range of cardiac manifestation can occur, and careful hemodynamic and electrocardiac monitoring should be undertaken in all patients. It should be remembered that hypoxemia, metabolic, and electrolyte abnormalities can all contribute to cardiac arrhythmia, and some arrhythmias may require cardiac pacing. Now, anticholinergic in the form of anticholinergic that we can give in the form of atropine. Treatment with the anticholinergic to antagonize muscarinic effect of organophosphate on CNS, CVS, and GI tract. It's still mainstay of treatment and should be started as soon as airway is secure. The recommended starting dose of atropine is 2 mg bolus. In subsequent doses, 2 to 5 mg every 5 to 15 minutes should be administered until atropinization is achieved. The signs of adequate atropinization include increased heart rate, moderately dilated pupil, reduction in bowel sound, a dry mouth, and decrease in bronchial secretions. Contrary to earlier belief, the total atropinization, that is fully dilated pupil, absent bowel sounds, heart rate more than 150, is no longer necessary. Satisfactory management involves keeping the patient adequately atropinized without attendant risk of total atropinization. Continuous atropine infusion are used in some centers in the dose of 0.2, 0.02, 0.08 mg per kg per hour. The dose of atropine required is maximum on the day 1 and tend to decrease over next few days. Atropine does not reverse the skeletal muscle effect. Then the next agent is the glycopyrrolate. So glycopyrrolate is equally effective with fewer central side effects and better control of the secretion. Then the next agent that we can use is the cholinesterase reactivator. So oximes are the nucleophilic agent that reactivate the phosphorylated acetylcholine esterase by binding to the organophosphorus molecule. The use of oxime in the organophosphorus poisoning has been controversial subject for last 2 decades, as there have been very few randomized control trials that have addressed the role of palidoxime. So palidoxime has three main actions. It is a direct reaction converting the organophosphate to harmless compound, a transient reaction protecting enzyme from the further inhibition, and the reactivation of inhibited alkyl phosphorylated enzyme to free active unit. So oxime reactivated acetylcholine esterase is inhibited by the uh, organophosphorus. So pyridoxine was discovered in mid-1950 by Wilson and colleagues and was soon introduced into clinical practice of patients with parathion poisoning. Other oximes such as obidoxime and the trimidoxime have been developed, but pyridoxine remains the most widely used. Despite the beneficial effect of pyridoxine first noted with the parathion poisoning, its effectiveness has been much debated, with many Asian clinicians unconvinced of its benefit. In particular, two randomized controlled trials are conducted in the Vellore in India in early 90s, noted that low dose of infusion of pyridoxine might cause harm. But the absence of clinical benefit could relate to the trial design because of the suboptimal dosage and the bias in the allocation. Alternatively, this result could suggest that pyridoxine is ineffective in the patient seen at hospital, perhaps because of the specific pesticide ingested, the amount of ingested, and the patient's long delay before the pyridoxine is given. So, subsequently, the Cochrane review and other two meta-analyses regarding pyridoxine was published. And the Cochrane review included the two randomized control trial, reported no clear evidence of benefit or harm. The other meta-analysis combined non-randomized or historically controlled observational studies with randomized control trial, reducing the confidence in their conclusion that oximes are harmful. Then since this meta-analysis was completed, the randomized control trial in Baramati, India, studied the effect of very high dose of pyridoxine, that is 2 gram loading dose and then 1 gram either every hour or every 4 hours for 48 hours and then 1 gram every 44 hours until recovery in 200 patients with moderate organophosphorus poisoning. So what they have found is this high dose regimen was associated with the reduced case fatality, fewer cases of pneumonia, and reduced time on the mechanical ventilation. Lab studies to identify the pesticide ingested and the degree of baseline acetylcholine esterase inhibition and subsequent reversal were not done in this study. However, this study suggests that the large doses of pyridoxine could have benefit if patients are treated early and have good supportive care. So, observational studies of pyridoxine and the obidoxine suggested that the ability to reverse acetylcholine esterase inhibition with oxime varies with the pesticide ingested, and the acetylcholine esterase inhibited by diethyl pesticide such as parathion and the quinolphos seem to be effectively reactivated by oxime, but acetylcholine esterase inhibited by the dimethyl organophosphorus such as monocrotophos and the oxydemoton methyl seems to respond poorly. So we noted that acetylcholine esterase inhibited by the S-alkyl organophosphorus such as propanphos is not reactivated by the oxime at all. So this difference is probably partly because of the variation in the speed of acetylcholinesterase aging induced by these different pesticides. Interestingly, this Baramati study did not find the difference in benefit of high dose predloxime in moderate diethyl and dimethyl organophosphorus poisoning. Oxime will not be effective for improvement of outcome if patient develops severe complication such as aspiration pneumonia and hypoxic brain injury. Such a complication takes place most often with fast-acting pesticides such as parathion and the dichlorops. So WHO recommended that oxime to be given to all symptomatic patients who need a treatment. To ensure therapeutic concentration, a loading dose of pralidoxime chloride and obidoxime is given, then continuous infusion. The loading dose of oxime should not be given rapidly as a bolus because this method causes vomiting, tachycardia, and diastolic hypertension. So the reactivating action of the pralidoxime is most marked at nicotinic and skeletal neuromuscular junction. It does not reverse the muscarinic manifestation of organophosphorus poisoning. So pralidoxime should be started as early as possible to prevent the permanent binding of organophosphate to acetylcholinesterase. Once this has occurred, receptor regeneration is required to allow recovery. The recommended dose of pralidoxime in the organophosphorus poisoning is 1 gram by intravenous injection in every 6 to 12 hours in the adult and 25 to 50 mg in children. So pralidoxime should be continued until spontaneous ventilation is achieved by the patient. The effective plasma concentration is 4 mg per liter and the patient should show signs of improvement in 10 to 40 minutes after its administration. Plasma and pseudocholinesterase level should ideally be monitored during the treatment. The side effects of the pralidoxime include drowsiness, visual disturbances, nausea, tachycardia, muscle weakness, so treatment should be reversed for potentially fatal cases. Now, the next agent that can be used is benzodiazepine. Patient poisoned with the organophosphorus frequently develop agitated delirium, and diazepam is the first line therapy for the seizure. However, seizures are uncommon in well oxygenated patients with pesticide poisoning, and seizures seem to be more common with the organophosphorus nerve agent. And the animal study suggests that diazepam reduces the neutral damage and prevents the respiratory failure and death, but studies in the human are few. Then other therapies are magnesium sulfate, which blocks the ligand-gated calcium channel, resulting in the reduced acetylcholine release from the presynaptic terminal, thus improving function at neuromuscular junction and reduce the CNS overstimulation mediated via NMDA receptor activation. A trial in people poisoned with organophosphorus pesticide recorded reduced mortality with magnesium sulfate. However, the study was small and the allocation was not randomized, and the publication incompletely described the dose of magnesium sulfate used and other aspects of methodology. Therefore, these results should be interpreted with the caution. The other agent is the alpha-2 adrenergic receptor agonist, that is clonidine, which reduces the acetylcholine synthesis and release from the presynaptic terminal. Animal study shows the benefit of the clonidine treatment, especially in combination with atropine, but effect in the human beings are unknown. Then sodium bicarbonate is sometimes used for the treatment of organophosphorus poison in Brazil and Iran in places of oxygen. The increase in the blood pH have been reported to improve outcome in dogs, through unknown mechanism. However, there is insufficient evidence exists at present to establish whether soda bicarb should be used in human poison with organophosphate. Removing organophosphorus from the blood could allow the optimum action of the other thing. The role of hemodialysis and hemofiltration are not yet clear. How a recent non-randomized control study in China suggested the benefit of hemofiltration after poisoning with the dichlorobus, which has a poor solubility in the fat, therefore should have relatively small volume of the distribution. But the systemic review of this therapy in the organophosphorus poisoning is underway, but the randomized control trial will be needed to establish good evidence-based treatment guide. Now, the butyrylcholinesterase scavengers organophosphorus in the plasma, reducing the amount available to inhibit acetylcholinesterase in the synapse. It has been cloned, and it has been cloned, and the military research now aim to inject soldiers with enzyme before exposure to the organophosphorus nerve gases. But such a prophylactic approach is not practical for self-poisoning with organophosphorus because we cannot predict when the person is going to ingest the pesticide. So one Turkish doctors have reported the butyl cholinesterase in fresh frozen plasma can be used in the treatment of poison patients. Furthermore, whether or not scavenging the organophosphorus by butyl cholinesterase is the mechanism for any effect of fresh frozen plasma is unknown. Thank you, guys.